So I will mute myself, Dr. Naveen.
Yes, sir. Sir, is my screen visible, sir?
Yeah, yeah, yeah. It is very much visible.
Okay, okay, okay. So, so guys, after two very interesting presentations by Dr. Srinivas, so first of all, I will let you know that there is a little change in the program. Like initially, Dr. Khurshid talk on ultrasound head was planned earlier, but now it has been shifted to the end. Why? Because he is in Calgary and his flight is reaching in another half an hour. But he was so keen and he was so generous that he said that in spite of that, he will take the talk at the end. So myself, I am Dr. Naveen Gupta. I am presently a neonatologist at Madhukar Rainbow Children Hospital. And after completing my DNB neonatology from Sir Gangaram Hospital, I went to Vancouver, Canada. And there I did my training in the functional echocardiography. And since 2010, 11, I am doing this point of care sonography. And there I met all these beautiful people. Khurshid was at that point of time my batchmate there, and who is now an authority in the neonatal neurology. Okay, so coming to this point. So now in the previous talk, you have all learnt about that how we should be doing all these how we shall be doing all these normal stuff. Now the point is, why do we do the echocardiography or ultrasound? So we want to infer that how it can help the child. So let's see that how it can help us. So I will go for the calculations. I will go the view wise. Like the first view, we started from the parasternal long axis view. So there will be few repetitions here because unless and until we will keep on intensify or stressing upon something that will not register. So in the parasternal long axis view, usually the pointer is kept towards the right shoulder. And I will just revise the chambers which will you will see from anterior to posterior. So although always remember that the pointer is towards the right shoulder of the probe, but here on the screen your pointer is visible on the left side. So this is the only point where in echocardiography, as sir rightly said, that you point your pointer towards the right side, but on the screen it is visible on the left side. So this is the only place where the disconnection between where you are placing the pointer and the pointer which is projecting on the screen is there. From anterior to posterior, the chambers are, which has been explained, the RV, the LV, this is the septum, and then you are seeing the LV outflow, which is the aorta, and you see the LV inflow, which is the LA. And always remember that LA is the posterior most chamber of the heart, and when it talks to anterior most chamber, it comes to RV, and anterior most vessel or anterior most part, it comes to pulmonary artery. Even if you look at the heart model or when you will do the hands-on. So why this view is important is one very important thing, like somebody was asking a question about duct. Every neonatologist is passionate in the preterm babies about identifying the duct and whether to treat that or not. So one of the parameter is when the duct is getting significant, the left atrium starts enlarging more and more as compared to the aorta. Aorta remains fixed in size, but the LA keeps on enlarging. How can we estimate the size of LA? For whether when the chamber is moving so much, we have to trace the movement of that chamber against the time. So that is called M mode. So when we have a moving things, the M mode helps us because against the time is always on the x-axis. Against the time, you see the movement. So same things are reflected in the M mode. You put your M mode right now because we want to see the relationship of iota and the LA. The M mode line should be crossing through the aortic valve and going to the LA. So the anterior most chamber is the RV. Here you will see the RV, and then you see the second one as the iota and the third one as the LA. And when you calculate the size, you can see that like in this place, in this case, the aortic root diameter was 0.6 and LA was 1.09. So it was coming almost double, 1.8 times the iota. So this is the ratio. Based on this ratio, people have people have differentiated whether the duct is mildly significant, moderately significant, or severely significant. So this is one of the parameters. People or neonatologists who want to treat ductus, they take this factor into account. And so one is this, we can see the ratio. Secondly, this is the best place where we can calculate the aortic root diameter. Remember the first principle talked by Dr. Murthy, that we have to, in the 2D mode or in the B mode, which is the structural mode, the structure which is perpendicular to the beam of ultrasound, which will be visualized best. So here the aorta is the perpendicular. So here you normally we calculate the aortic diameter. We can calculate it by freezing this image. When we freeze this image at the hinges, we can calculate it, or we can calculate either the M mode here also is giving us the diameter. Why this diameter is important, we will see in the next slide. Okay, another important, so diameter is important for the left ventricular output calculation, that we will see in the subsequent slide. Another thing which can be calculated in the parasternal long axis view is the fractional shortening. Neonatologists or physicians or the pediatric intensivist, when they deal with the sick child, they are always interested in knowing whether the child is in shock or not. So in adult cardiologist or the pediatric intensivist, they tend to assess it by fractional shortening. What is fractional shortening? It is that how much movement the left ventricle is doing during the diastole and systole. If the if the muscle is good, then the difference between the left ventricle and diastolic diameter, so left ventricle and diastolic diameter minus left ventricle and systolic diameter divided by left ventricle and diastolic diameter. So if the ventricle is pumping good, then this difference is more, right? So that means the fractional shortening will be more. If this difference is less, that means the contraction is very less. So where can we assess this fractional shortening? It is in the parasternal long axis view, but in the previous slide, the M mode beam, I am going to the previous slide, M mode beam was vertical. It was involving the aortic valve and the LA, right? And now the beam should be at the tip of the mitral valve. So the principle is that the beam should be at the tip of the mitral valve. Why? Because at the level of the mitral valve, the LV diameter is maximum. So you understand, when we draw a four-chamber view of the heart, so if this is the LV, the dimension of the LV is not uniform, but at the level of mitral valve, it is the maximum. And secondly, this M mode should be perpendicular to the interventricular septum. So this should be perpendicular. If this will not be perpendicular, you will underestimate the fractional shortening. So we put the M mode here. When we put the M mode, again, the anterior-most chamber becomes the RV. Then this is the interventricular septum, and then this is the LV. And this thing which we are seeing, this is the movement of the mitral valve. So here is the place where the mitral valve is meeting. I think whatever I am drawing with the pencil, that is seeing, right, sir? Can somebody please tell me whatever
Yes,
I'm
sir.
drawing with the pen?
Yes, sir.
Yeah.
Yes, sir.
Yes,
Yes,
yeah,
sir.
it's
Okay.
very nicely seen.
Visible. Okay. Okay. Right, sir. Right. I thought sometimes after 40 minutes I come to know whatever I am doing, it is
No,
not
no,
visible.
no,
So
no. I have just unmuted so
okay.
that I can listen to it without interruption. That's all.
It's okay. It's okay. Thank you, sir. So that's the interventricular septum, and these are the mitral valve leaflets. You see the mitral valve leaflets. They are they are coming opposed to each other. That happens when there is a systole. When there is a diastole, the two leaflets, they open up, right? So we can do one measurement at the end of the systole and one measurement at the diastole when it is the maximum. So this is the LV end diastolic diameter, this is the systolic diameter. You do minus, and then this is. The problem is that the neonatologists, they don't use it too often. Why they don't use it too often is, One is that one is that this is very much prone to the error. Okay. So, and second is that the interventricular septum doesn't move so well because of the RV predominance, as Dr. Murthy has elaborated. The septum doesn't move so much. So sometimes the fractional shortening is not the one of the best parameters in the newborn to assess whether your how ventricle is pumping. However, visibly looking at it will give you a very good idea. When the scan, I'm just going out of the presentation for a minute. When the scan was initially inaugurated and initially thought of by Dr. Sumesh, Dr. Prasant, and the group, so they thought that this is usually for the like we have to screen the normal things. We should not go into the depth of this. Why we have included this is now because the people are now with the more and more usage of the point of care sonography. Everybody is more and more interested in what next to do, what next to do. So this is how we calculate the fractional shortening. When we have to calculate the ejection fraction, this thing goes by the cube. So if you are mistaking 2 times, you are mistaking it actually 8 times. So that is why ejection fraction is again a wrong way. So the fractional shortening you can calculate only actually visibly looking will also let you know that how good or how bad is the contractility. But so this is again in the Planck's view. So in the Planck's view, you will measure three things. One is aortic root diameter, one is LA by AO ratio, and the third is you can calculate the fractional shortening. Okay. So this was about the parasternal long axis view. Now, second, coming to the apical view, we do many things in the apical view. So what I will do is we will go by one. Most important thing whenever we see that whether our what we are dealing with is, so normally in clinical practice we don't do echocardiography for each baby. You will do in a preterm baby who you want to look for a PDA. You do in a term baby when you want to look for PPHN. Term baby who is in hypoxemic respiratory failure. You do in any term baby who is not maintaining blood pressure or who is looking sicker or who is on high ventilation needs to assess how well or how good the contractility is. So left ventricular output means that in 1 minute, how much the left ventricle is working or it is ejecting the blood. So this is a very, very good parameter to assess the systemic organ perfusion. So I repeat this statement. So LVO is a good parameter to assess it can be a surrogate marker of systemic perfusion. The problem is it is not a good parameter in preterm babies, preterm very low birth weight babies in first 48 hours of life when the shunts are functioning. कौन से shunt होते हैं? Which shunts are there? One is the atrial shunt, which is the patent foramen valve, and one is the PDA. We will discuss this, but remember, if you are dealing with a term baby after first, second, third day of life, or sorry, preterm baby after second, third day of life, where there are no shunts, or a term baby, the LVO can be considered as a good surrogate marker of systemic perfusion. Good surrogate marker of systemic perfusion. Because we at the end of the day our goal is to know whether the baby is in shock or not, and shock is when the baby is not getting sufficient oxygen. So this is a apical 4 chamber view. 4 to 5, this is basically the tilt of the apical. So when I'm looking at, so if I freeze it here, okay, so I freeze it here, so you see the 4 chambers, the LV, the LA, the RA, and the RV. Okay, and the pointer is towards the left side. Your marker is fine. You go a little bit, you do anteriorly, and you open the iota, which has been aptly explained by sir. You do little bit more anterior tilt with a clockwise rotation, and you open. Just a minute. I will. Okay. So you open this. I will. Give me 1 minute. Okay. Okay. I will. I will remove this. So this is the pulmonary artery. So this is the pulmonary artery which is arising from the RV. So see, apical view is so nice that you can see the four chambers. You can see the relationship between the four chambers, that how they are related to each other, specifically the LV and the RV. Little bit of anterior tilt, you open the aorta. Why the aorta is important? Because that is the place where you will measure the left ventricular output. And little bit of more anterior tilt, you can see the pulmonary artery which is arising from the RV. Okay. So we go to our principal thing. What we wanted to show here is, okay. So basically, which is the point where we need to measure it? Okay, so this is the point. So when we see that the aorta is opening up very well, we have to measure the output here. So to measure the output, we will use Doppler. Remember the first presentation that, so if we want to see that how fast the blood is going, so that velocity is being estimated by the Doppler. Okay, let me ask you one question. I mean, I will answer myself only because it's not physical. So my probe is lying here. My probe is lying here, and the blood is going from the LV into the aorta. So the color of the blood, color, if I put the color mode, it will be blue or red. It will be blue. Why? Because as sir explained, but blue is blood going away from the probe and red is coming towards the probe. So when you put the color mode, you will see a blue thing, right? You will see a blue thing. So when you see the blue thing, so everything is fine. Now the next step is, so we will put the pulse Doppler, and the pulse Doppler has got a range gate. So sir told that there are two kind of Doppler we use in the neonatology or in the echo. One is CW, that is the continuous Doppler, and one is the pulse Doppler. The pulse wave Doppler is used all the circumstances except one where continuous wave is used, where the very high velocity flow is there. So that is to estimate TR jet in PPHN. So basically, continuous wave Doppler estimates the velocity throughout the beam, and pulse wave Doppler estimates the velocity at a specific point. Like in case of LVO, when we have to, we want this specific time point, and the specific point is reflected by the range gate, which are two horizontal bars. Okay, so let's see how it happens. So this was the baby, and we estimated you see, this is the pulse wave Doppler. You can see the two horizontal bar here, and you see this kind of a wave. Then you need to trace this wave. See on this graph, on the x-axis is the time, and y-axis is the velocity. Okay, and this velocity time integral, which is called VTI, velocity time integral. So velocity time integral is when you trace this envelope. Okay, so the machine will do it automatically also, or you can do manually also. Velocity time integral is area under the curve of the velocity, in which x-axis is velocity and t-axis is time. So this VTI actually is stroke volume. So in one ejection, like this is when LV is pumping systole, this is again systole, this is again systole. This area is the diastole. So in one pump, how much blood is being ejected? So this VTI, it will calculate like it is 14 centimeter. We calculated aortic root diameter 0.6 in the parasternal long axis view, which was shown in the last slide. We need two other parameters, heart rate 138 per minute from the pulse oximeter and the weight of the baby. Now, how do we calculate? First, we have to calculate how much is the stroke volume. So first we calculate the area. So area is, because through how much area it is going. So area is pi d square by 4. So pi is 3.1427 multiplied by d square is 0.6 into 0.6 divided by 4. This comes as 0.28. I just calculated it 10 minutes back. So this is 0.28. Now this is the area. Now when you multiply the VTI into this area 0.28, so this becomes your stroke volume. So it is coming 3.92. Okay, so this unit is centimeter, VTI is centimeter, you can see it here. Area is centimeter square, so this becomes centimeter cube, and centimeter cube can also be seen as ml. Now in one ejection, the ventricle is ejecting 3.92 ml of blood. But we want to see in how much it is happening in 1 minute. So for that, we have to multiply this by the heart rate, right? So when you multiply it by the heart rate, it comes 540. So 540 ml per minute. In one injection, it was 3.92, and in 1 minute it is 540 ml. Now, if a baby's heart is beating at 200 ml, this will again be more. So the same action when you give epinephrine, because it has got a chronotropic action, you want to get use of it. Anyhow, but now this 540 ml per minute may be very high for a 0.5 kilo baby and may be very low for a 4 kilo baby. So we have to standardize it. For standardizing it, we divide it by the weight of the baby. Like in this case, the weight is 1.8 kilos. You divide it and you get 300 ml per kg per minute. So this is the left ventricular output. So whenever you do POCUS, you should always mention your finding, and this left ventricular output should always be there. So you encounter a baby, initially the LVO is less. You start inotrope, the LVO increases, whether it happens or not, but suppose it increases, you will come to know that you are going in the right direction. You can assess the same things by clinical parameters also, but sometimes learning this POCUS is very, very handy. If we will have any question, I will take later on, but this is how we calculate any output. So for any flow measurement, like somebody was asking about SVC, so for any flow, you go through the same way. You need diameter, you need a VTI, and then you assess that area, you multiply it by diameter. Once you multiply it by diameter, then you multiply by heart rate, and then you divide it by the weight. So this is the formula. First, you calculate the area, then VTI multiply by heart rate, multiply by area, and you divide it by weight, you get the any output. This in this case, it was LVO because we calculated for aortic root diameter. In SVC flow, the same thing. You calculate the SVC diameter, you calculate the flow VTI, you have the heart rate, and you have the weight. Okay, so coming to the next, in apical view, if you have a baby who is having a PDA, if you have a baby who is having a PDA, what you do, what do you want to see? We want to see, sorry, if you have a baby who is in hypoxemic respiratory failure and in whom you are suspecting pulmonary hypertension, what do we want to see? We want to see that how much are the pulmonary pressures? How much are the pulmonary pressures? I'm sorry, I just, oh shit. Okay, so we want to see that how much are the pulmonary pressures. So when we have to assess, these pulmonary pressures, what will we do? we have to go for the apical view. In the apical view, you have four chambers like LV, RV, RA, and LA. So at the tricuspid valve, you will put the Doppler. And this condition, which Doppler is used, I told you everywhere pulse Doppler, only one place where continuous wave Doppler, and that is for pulmonary pressures. And you get this kind of the waveform, and you put the machine will automatically calculate. In this waveform, again, this is the time and this is the velocity. Why it is coming down? Because the blood is going away. When you will put the color mode here, you will see a blue jet going in this direction. You will see a blue jet, and you will see red here. Why you red here? I can draw it with this thing. So basically, if I, so you will see blue this thing, and you will see red this. Why red is the flow which is going from the RA to the RV, and blue is the when the RV, because RV is unable to pump against the high pulmonary vascular resistance, RV is pumping back the blood. So you see a blue jet, and when you see a blue jet, you put the continuous wave Doppler, and then you get this kind of a circular waveform. I should have got it fully, but sometimes you are not able to get the fully. So then you estimate that how much is the pulmonary pressure. So you estimate this gradient. So gradient is the difference in the pressure between the RV and the RA. So with how much, so that gradient we can calculate, and this gradient the machine is calculating as 39.5 because we have put our cursor here. This you go into the calculation. If you don't have this thing, we can calculate it by the formula, which is the 4V square. So velocity is being estimated here, TR maximum velocity, and you scale it like you have to go it by meter. So 3.14 square into 4. Okay, so this will give you the pulmonary gradient. And you see here pulmonary gradient is 39.5, but RVSP is right ventricular systolic pressure. It is coming 5 higher. It is 45.4.5. Why that is so? Why that is so? Because you estimated gradient by 4V square, or the machine will do it. When we calculate for right ventricular systolic pressure, so we this pressure gradient is being calculated and we estimate the pressure of the RAP. See, when RV, RA, when we are estimating the gradient, that is RV minus RA. Like in this case, it was 39.5. Suppose RA doesn't have any pressure, then the pulmonary RVSP, right ventricular systolic pressure, is 39.5 only. But when the RA has some pressure, so that thing has to be summed up, right? So suppose here it is 44 and here it is 5. So what is the gradient? Gradient is 44 minus 5, which is 39. Machine is calculating 39. So whatever the machine calculate, you add 5 to 10 to it, because RA has got that much resting pressure in a spontaneously breathing baby. So that is the RAP, which is the right atrial pressure. So I repeat, so till now we have learned that parasternal long axis view, we used to take aortic root diameter. We can take LA by AO ratio, which is good for the PDA. We can take fractional shortening. Second is the apical view, where we can calculate the left ventricular output, and in case of PPHN, we can look for the tricuspid regurgitation. Similar way, we can also calculate the mitral regurgitation. You put the continuous wave Doppler at the mitral valve. So basically the principles remain same. You need to understand what you are looking for. Many cases with shock, they have biventricular dysfunction and they will have both TR and MR. Another thing which is actually very, very new these days, sorry, this is, so, yeah, okay. In spite of crossing that, I need to go that way. So another thing which is very, very new these days is TAPSE. What is TAPSE is tricuspid annular systolic excursion. You want to see that how much the flaps of the tricuspid valve, they are excurting during the systole, right? So this is again taken as one of the parameter for the pulmonary hypertension. If the RV pressures, if the pulmonary artery pressures are very high, the RV will not be able to relax so much. So the contraction of the RV dysfunction sets in, and when the RV doesn't contract so much, the tricuspid valve is not moving so much. So this is done with the help of the M mode. You put the M mode on the free wall of the right ventricle, where the tricuspid valve is originating, and then you see this kind of a wave. Okay, and from the baseline you take the how much the excursion is there, and then people have values like as per the gestation age. If you want to go into depth of it, you can easily go into depth of it. So this is mainly just to sensitize you that this is again one of the parameter. When we go do a complete focus for persistent pulmonary hypertension in a stepwise manner, TAPSE is again one of the parameter. Okay, E by A wave and IVRT. This is I will leave it for the end of the presentation if we will have time, because this is little bit more physics. So give me some time that I will explain you about this. So I will just leave it. Why? Because I want to go for the other part. I will come to it if we will have time. So people, you want to assess the right ventricular output. Why? Because sometime in cases of shock or PPHN, you want to assess separately how much the RV is pumping. So for RV output, again, what do you need? You need diameter, you need flow, right? So now tell me, for flow, what was the principle? To estimate the flow, if your flow is in this direction, your ultrasound beam should be parallel. If suppose flow is in this direction and your ultrasound beam is like this, you will always underestimate the flow. This angle is called angle of insolation. Okay, so which is the view Dr. Srinivas told you where the flow of pulmonary artery is parallel? So two views can be used. One is the parasternal short axis view or the parasternal long axis view superior tilt. In parasternal long axis view superior tilt, we were opening the pulmonary artery. So just for revision, parasternal short axis view, what are the chamber? The central one is the aorta. Posterior most chamber I have told you always remember is the LA. This is the interatrial septum. This is the RA. This is the RV. And this is the pulmonary artery which is arising. Now your probe is here and the blood is flowing from the RA into the pulmonary artery. So which color is it? Blue. And it is reflected as blue. But you see something red coming here. I think all of you can see. What is this red coming here? So this is PDA. This is the ductal flow. Okay. Anyhow, so this if I put my pulse range Doppler, so this is almost parallel flow. So this is a very good view where we can estimate the right ventricular output. So again, I put my pulse Doppler. So this is the line of pulse Doppler. You can see the two horizontal bars in this, and they should be at the level of pulmonary valve. You do it and you see this kind of the waveform. Why this turbulence is there? This turbulence is because of the duct. Because with lot of flow, this red color blood is coming in the opposite direction. So that is why you see this turbulence. Okay. So the principle remains same. One is diameter. For diameter, we have to see the diameter here of the. You will freeze the image. You will freeze the image, and after freezing the image, you can assess the diameter. I will show you where, and then you do the pulse wave Doppler, and on the pulse wave Doppler, you estimate the stroke volume. You estimate the velocity time integral. Once you estimate the velocity time integral, the formula remains same. And what was the formula? And what was the formula? The formula was, so that I'm repeating it so that it gets revised with you guys. So the purpose is so you get more and more repetition. So the formula was VTI into area. Area you will calculate after diameter pi d square by 4 into heart rate divided by weight. Okay. So remember this area, and by the help of this, you can calculate the right ventricular output. Okay. So right ventricular output we can estimate in case where LVO is not true marker of surrogate systemic perfusion, like when there is a hemodynamic significant ductus. I will explain you why it happens. There is a schematic diagram. Okay. So now when your baby is in shock, one thing we want to calculate what is the output. We have learned how to calculate RVO. We have learned how to calculate LVO. We have also learned about fractional shortening if we want to calculate. Another thing is volume. So whenever their baby is in shock, there can be only three causes. One is if the volume is less, any bleeding, anything, if the volume is less. Second is the volume is adequate, but the heart machine is not able to pump because intrinsically it is bad. And the third is everything is right, but the heart machine has to pump against a very, very high resistance, which is called increased afterload. So these can be the three reasons. So, so these can be the three reasons. So how to assess the volume? So volume assessment, again in the just a minute. Again, in the pediatrics and in the adults, people use inferior vena cava very much to assess the volume. Now, in newborns, what we have seen is that it may not be a very good surrogate marker of volume because it is affected by majority of these babies, they are ventilated. So when you in the ventilator, when you provide positive end expiratory pressure, you can your IVC will look very much dilated. Sometimes your baby is on HFO, very high MAP, again IVC may be dilated. So a visible seeing of the four-chamber view will give you a very good idea of the volume. So if sometimes you see the kissing ventricle, that is like the ventricle is so underfilled that both these valve and this valve, they are very much near to each other. So this is called kissing ventricle, which may be sometimes when we can give fluid. However, we should know that how to assess it by the IVC. So how to assess volume, inferior vena cava, and looking at the four chambers. So this is the way of how do we look for inferior vena cava. Sir told you it's in the subcostal view. Your probe should be in a longitudinal direction. The tip should be at 12 o'clock position, pointing superiorly, right? And you do a little bit of right side tilt. And you will see this thing, which is called inferior vena cava. And this is where it is entering is RA. Okay, right? And this is the hepatic vein. Okay, so this is inferior vena cava. Sorry, just 1 minute. Okay, IVC. Okay, so now how do we assess the diameter? One is you visibly look at it. After seeing hundreds of inferior vena cava, you will be able to see, okay, this is lesser in diameter, this is more, or this is more. Another thing is, again, inferior vena cava diameter is changing during inspiration and expiration. Inspiration and expiration. When the diameter is changing during inspiration and expiration, which mode you will need to assess how much is the diameter in inspiration, how much is in expiration. Apply the same physiology which we're applying when we need to calculate the fractional shortening, where we wanted to assess the diameter of the left ventricle during diastole and during systole. So same for the IVC. So you put the M mode. M mode. M is the moving. Na? So it will assess against the time. It will see that how much is the diameter of the inferior vena cava. So it will tell you one diameter during the expiration and one during the inspiration. So, okay. So sorry, here the subsequent slides are not there. But so once you can assess this, and then you can go for the collapsibility index or the distensibility index, where you do this minus this divided by this. Okay. So basically it is again where too much variations are there. This is not a very, very standardized way. Like I give you an example, we looked for, that is right now not published, but we are going to publish soon. We looked for 500 babies. We thought that in newborns, let's first see that how much is the average diameter. So in a spontaneously breathing, healthy, late preterm and term baby, we tend to assess within first 6 hours that how much is the IVC diameter. So it's very, very narrow, very, very narrow. So we need more research in the newborn period before we need to jump upon giving fluid boluses based on the IVC or restricting ourselves. Okay, so I was telling you about the visible thing. You see there are two heart videos I am playing. This video, how do you see the contractility? I think it's a good contractility. You can see that the muscle is pumping good. And how do you see it here? It's very poor. See, there is a flicker of the motion. So it's a poor contractility. So this is how, once you will start doing more and more echoes, so after few echoes, you will come to know whether the contractility is good or the contractility is not good or it is poor. Okay, this is somebody who was asking about superior vena cava. So SVC flow. I will spend 2 minutes because people have lot of interest in this. So for any flow, you remember for any output, what do we need? Two parameters. One is diameter and one is flow. So diameter best is when your beam is perpendicular because it is taken in the 2D format. And flow is color thing, pulse wave Doppler, and it should be parallel. So first locate where the SVC is perpendicular. So which is SVC? So this is a modified parasternal. I will not say long axis view. This is a modified parasternal view. This view was not depicted in the journal thing. We will show you on the simulator, right? That how where we can put it. But basically, how I shall tell you, it's unless and until we are physically there, I can't tell you that how do we locate it. But in the parasternal position, we tend to place the probe and we tend to look for this. I will tell you on the physical sheet. And then you see that this is the RA and this vessel which is entering is the superior vena cava. Okay, and on the top of superior vena cava is aorta. So this is a little unusual view, but this is how you assess it. And you see what are these things are going. So physically, if you would have present, I would have asked you, but this is the lung and they are the B lines of the lung. Okay. So this is where you assess the SVC diameter. So you can freeze this image. So like suppose I freeze it, and then you at that point where it is entering the RA, you assess this diameter. And the second way of assessing the SVC diameter is because it also may change a little bit. You can take the mean during the inspiration and expiration, but for that you have to use the, for that we have to use the, just a minute, close the door, close the door. So for seeing the diameter during inspiration and expiration, fully, for seeing the diameter during inspiration and expiration, we have to use the M mode. Okay, so superior vena cava, I think somebody was asking. So for the first place where we have taken the diameter, and then the second place where you will seek the flow. So for taking the flow, your flow should be parallel. So you go into the subcostal area, and in the subcostal area, your probe is in a transverse position, and this pointer is towards the left side, and then you almost insinuate it beneath the xiphisternum so that it goes parallel. See, the superior vena cava is coming from the back, so this is the SVC, and this is here, it is entering into the RA. So you insinuate it where you can see that this is the subcostal view. My probe is here, and if you see this thing, so these are the ventricles, these are the LA, this is the LV, and RV, very minimal we can see, because we want to see how the SVC is entering into the RA. Okay, right? So this is the place where this flow is parallel. So what I will advise to do is, whenever we have to estimate the flow, so we will put the pulse Doppler and the range gate here, where the SVC is entering into the RA. Okay, and then you will get a waveform. In the next slide, I should have shown the waveform. Let me see. Okay, yeah. So this is the waveform. So your point, the pulse wave Doppler is here, and this is the kind of waveform which you will see. You see there are two humps which are visible in the SVC flow. Why the two humps are there? So the two humps are there because the first hump is when in the early part of the diastole, the tricuspid valve opens up. Lot of flow goes from the RA to the RB. And then in the later part of the diastole, when the RA contracts to push the remaining blood. Okay. And then you calculate again the velocity time integral, area under the curve, and the same formula. So I will revise the formula. You calculated diameter previously, so you can calculate the area, multiply by velocity time integral, multiply by heart rate, divided by weight. So people have used superior vena cava flow where? In the preterm, very low birth weight babies. See, read this line. In very low birth weight babies with shock in first 48 hours of life, when LVO, left ventricular output, and RVO are not true surrogate markers of organ perfusion because of the presence of left to right shunt at PFO and PDA. I will explain in a schematic diagram. SVC flows can be taken as a surrogate marker. But the problem is there is a huge inter-observer and intra-observer variation. When I was learning it, the SVC flows, they were new kid on the block and people were using it very much. But what I observed is that it disturbs the child too much. We do it in 600, 700 or 1 kilo baby. Baby is already on ventilator. And then there is a huge intra-observer and intra-observer variation. So over the years, the people have started now looking at it less and less. But yes, you should be knowing it, that how do you take it. So I think this was about the calculations part. And where do we can apply all these calculations? In shock, PPHN, PDA, or to estimate the organ perfusion. This is the last slide, which sums up all. In shock, when you look to for preload, you can look for the inferior vena cava diameter or the collapsibility index. Then the visual estimation remains the gold standard or the best way in the newborn. For assessing the cardiac contractility, you go for the apical four-chamber view. You calculate the LVO for the left ventricle contractility, RVO for right ventricle. But you can, yes, also assess the fractional shortening, which was there in the plaques view, or you can calculate the ejection fraction. This fractional shortening can also be calculated in the parasternal short axis view, PSAX, where Dr. Murthy was telling you when you start looking downwards towards the apex. So at the level of mitral valve, remember the video when he showed where there was a fish mouth valve, you can do it there. Diastolic dysfunction, E and A and IVRT are there. This actually I skipped. Let me see how much time is there and then I will try to explain, and the parameters which are specific to etiology. Thank you. Before going to the PDA talk, I would like to have few questions on this if you have any. Let me see if there are any questions in the chat box. Okay, slide is not moving. I think it was moving after that session, right? So can we have questions?
It was moving for me. I don't know whether it was an individual problem. There was no problem at all in the presentation.
Right. So participants, can we have questions? If you have any, you can ask, please. Dr. Amit, are you a little bit clear about the SVC thing? I don't think so. He is here.
Yes, sir. Yes, sir.
Okay. Okay. Any questions? So shall I go for the next presentation?
Yes, sir.
Okay. Okay. So Dr. Parnika, so normal value of collapsibility index and fractional shortening. So very nice, Dr. Parnika. So different cardiologists go for different things. Fractional shortening, usually less than 25 is very bad. 25 to 40 is okay. More than 40 is, good contractility. But less than 25, people are worried. Sometimes less than 40 also. Collapsibility index, you can just look at it because I normally doesn't do it so much. So so I will not be able to tell you the normal values, but from the I will message you from our study. What did we find in the normal babies about the collapsibility index?
I think it is less than 30%, which we take it as something
Normal.
intervene. 30 to 50% we are okay. Above 50% we are going to decrease the fluid. That is what the practice in my unit might be.
Very nice.
Elsewhere. Yeah. So 30 to
Yeah.
50% is something which I take is okay to continue with the same fluids. Less than 30% give bolus. Again, depending on the baby's condition, I wouldn't go for 10 ml per kg. Rather, I would go for 5 ml per kg, reassess, and then think of giving another 5 ml per kg. If it is more than 50%, and as you show, I have shown in the apical view, the ventricle seems to be quite juicy and big, then you might even come down on the fluids a little bit. So that's what I take in my unit, but yeah, it's very different practice elsewhere.
Very nice. Sir.
Yeah, Dr. Naveen, hello.
Yeah.
In a ventilated baby, is there any role of using this IVC collapsibility index or no role at all?
So in pediatrics and adults, yes, they use it. Why? Because they say that even if the diameter in the ventilated baby is coming more, but if the difference is there because of inspiration and expiration, you can see whether the baby is fluid responsive or not fluid responsive. In the newborns, we have actually limited data by whether we should use it or not. But I personally feel if the four chambers they are adequately filled in volume, they actually suggest that this is a good volume stage, and at the same time you will also assess what is the underlying etiology also. So sometime by history only we come to know about that. So that's what my perception is, but I feel that more research is needed before we start just pushing on fluids based on the collapsibility index in a ventilated baby in newborns.
Right. Thank you.
Need to be very careful at that time. Correct. Only thing is, if you have kept the PEEP constant, and if you are measuring serially, then it might give you some idea about the change rather than the absolute number. You can measure the collapsibility index frequently if you are worried about the fluid status. And if the PEEP has not changed, if the conditions not drastically changed, the lung conditions not drastically changed, then you might use the change as one of the indicator. But again, it is not the greatest way of doing it, but it's better than nothing. But still, I agree. If you just look at the apical four chamber, see the ventricles, that eyeballing gives a very, very good information. That's what I would say.
Yeah, so sir very rightly said that all these parameters at one point, rather than they may not be so informative, but yes, serially they will definitely be informative in the same baby by whatever interventions you are doing. And I think Dr. Pradeep, who asked the question, he is already a very high expert on this functional echocardiography, and sir, you rightly said. But this collapsibility index is generating more and more interest. Also, Dr. Koshki is asking. She is sir heading the neonatology at Max Shalimar Bagh. What sir said, collapsibility index more than 50, we will restrict fluid. Is it not reverse?
Yeah. I think I told wrong. Sorry. Yeah.
So more the collapsibility index, that
More
means that it's fluid responsive. So
Correct.
give fluid.
I did. Yeah. Sorry, I did reverse that statement.
Yeah. So Dr. Koshki, thank you for listening it carefully. You picked it up. So Gaurav, to everyone, sir, high PEEP and CI. So Gaurav, that's what our point was, that if the PEEP is very high, so collapsibility index may change. So I tell you, in pediatrics, yes, they take it. They say that if the collapsibility index is there, so that means that if it is more, that means that it's a fluid responsive state. Why? Because IVC is collapsible. So we do not know. See, physiology changes, our things changes, and in newborn, actually, genuinely speaking, we don't deal with the condition in which you have to push in more and more and more fluid as compared to the PICU where you see with the dengue shock and all those things. Koshki, you are right. Yeah. Anybody else apart from IVC? Okay. So I go for the next presentation. So shall we take a 5 minutes break, sir?
Yeah.
For the delegates also, I think.
Yes, sir. Yes, sir. We need a break.
Okay. So right now the time is 11:15 and we reassemble at 11:20, right?
Yeah,
Okay.
keep
Okay.
logged in.
Okay, sir.
You keep also logged in. Otherwise, relogging might take some time.
Yeah. Please keep logged in. So it's a 5-minute break, and next presentation is on PD. I muted myself. So okay. Good afternoon, everybody. Am I audible, sir?
Yeah, very much.
Okay, so we shall restart the thing.
Yes.
So,
correct.
so the next presentation is on the hemodynamically significant ductus.